Hi, everyone. Thank you for joining us on our Thursday afternoon webinar series. My name is Lourdes. I am Director of Patient Services with the Cholangiocarcinoma Foundation. I am happy to introduce our speaker and panelists for today's webinar. But before I do that, I just want to give a friendly reminder to those who are joining us. If you have any questions, you can add them into the Q&A or the chat. Please make sure that you have your questions as general as possible and not anything that's personal, since no one on the panel is able to answer specific questions. But now going on, I want to introduce Dr. Louise Connell. She is a medical oncologist at Memorial Sloan Kettering Cancer Center. She's experienced in caring for patients with cholangiocarcinoma. She's a leader in HAI therapy, a regional approach that she incorporates along with systemic chemotherapy in her practice. I also want to introduce Rick Brooks. He is a cholangiocarcinoma survivor and has been living with the pump since 2016. He's a CholangioConnect mentor. He enjoys golf and lives in Cramerton, North Carolina. And his third granddaughter was born last month. And I also want to introduce Amy Duff. She has been living with the pump since 2022. A year after her cholangiocarcinoma diagnosis, Amy lives in Branchburg, New Jersey, and enjoys long hikes, bike rides, and spending time with her family and friends. And Dr. Connell, I will hand it off to you.
Thank you, Lourdes, and thank you everybody for the opportunity to talk today. So the webinar today is really designed to allow you to ask questions, but we just wanted to start off first of all with some slides as a background. So hopefully you can see my screen. Okay. So first of all, just to mention my disclosures as listed here. And then just to set the scene. So intrahepatic cholangiocarcinoma affects approximately 4,000 to 5,000 patients each year here in the United States. This is a cancer type that is most commonly not operable. So only 20 to 30% of patients can have an operation or be resected. In those patients who are suitable for an operation, there's a high rate of cancer recurrence. Which can vary up to 60 to 70% even after a curative surgery. What we also know for patients with this cancer type is that controlling the disease in the liver is what's associated with improved survival. So what is hepatic artery infusion therapy? So if we think about traditional chemotherapy is delivered through a vein, and the drug travels through the body's bloodstream to reach the liver, with only a small portion of the drug ultimately reaching the tumors in the liver. Whereas with hepatic artery infusion therapy, and I have a graphic here just showing the pump, this is delivered through a pump which is implanted just below the skin in the abdomen. The drug is administered through the hepatic artery directly to tumors in the liver, and it treats the entire liver. With this technique, we can achieve up to 400 times a higher drug concentration in tumors in the liver. And just to explain, the hepatic artery is a blood vessel, one of the main blood vessels to the liver, which supplies blood to tumors in the liver. So this slide is quite data heavy, but where's the clinical evidence for the use of hepatic artery infusion therapy in unresectable patients with cholangiocarcinoma? So this basically was a meta-analysis, which is a review of 9 publications that looked at 154 patients, which demonstrated that with hepatic artery infusion therapy, there was substantial improvement in survival for patients with this cancer type. And what we found is that using a combination of liver-directed chemotherapy and systemic chemotherapy, it was a close to 40% 3-year overall survival rate. And this is, significantly improved compared to a very sobering number, which is less than 3% survival, which was reported in our early clinical trials for cholangiocarcinoma, the ABC trials, where only systemic or whole body chemotherapy was used. So with hepatic artery infusion therapy, it was associated with a 10-fold greater 3-year overall survival for patients versus that historical control, which at the time was gemcitabine cisplatin chemotherapy. One question that often comes up for me in the clinic is looking at the comparison between hepatic artery infusion therapy and immunotherapy. And this slide again has a lot of information on it, but I think what's clear looking at the three graphs is you see a much larger separation of the curves in the HAI therapy slide, which is on the left-hand side versus immunotherapy. So the PUMP2 trial is the most recent trial that we have in cholangiocarcinoma using hepatic artery infusion therapy. It was presented at one of our major conferences this year, ASCO GI in San Francisco. And this was a trial from the Netherlands where we saw that with the use of hepatic artery infusion therapy, there was almost a 10-month improvement in survival compared to gemcitabine cisplatin alone. And putting that into context, looking at our immunotherapy trials, with the TOPAZ-1 trial, which came out in 2022, adding the immunotherapy checkpoint inhibitor durvalumab to gemcitabine cisplatin led to a 6-week improvement in survival. And then similarly with the Keynote 996 trial, this used a different checkpoint inhibitor, which was pembrolizumab. Again, the same chemotherapy backbone, which was gemcitabine cisplatin, and an 8-week improvement. Of course, having to be mindful that, it's difficult to cross-compare trials, but just putting this into context and the role that hepatic artery infusion therapy has for patients. So this is a case study. This is actually one of my own patients. So this is a 73-year-old lady who had a history of hepatitis C, and because of follow-up for her hepatitis was having an annual ultrasound. And she was found, incidentally, to have a liver mass on her ultrasound in October of 2021. She went on to have further testing. This would be pretty standard, an MRI of her abdomen and a full CT scan looking at the liver in more detail. And what was seen was just over a 5-centimeter tumor. You can see the imaging at the top here on the right-hand side. So the tumor is marked off there. And what's interesting to note is that it's in a very difficult location in the liver because this is really a very important area in terms of blood vessels and bile ducts. So a tricky enough tumor to remove by surgery. As would be standard, she was checked with both endoscopy and colonoscopy to rule out any other possible origin for the cancer. And she had a liver biopsy, which proved to be an intrahepatic cholangiocarcinoma. And nowadays, as with all cancers, we check for mutations. Are there any targeted drugs out there? Is there any drug options? She did not have any targeted drug options based on her testing. She was presented at our tumor board, and in her case, her tumor was considered not operable because of the level of blood vessel or vascular involvement. And so she was recommended for placement of hepatic artery infusion pump. So she started on chemotherapy with me in November of 21, and she had the HAI treatment, which is floxuridine, with gemcitabine and oxaliplatin. She had, as you can see, for 9 months, from November 21 to July of 22. The CA19-9, her tumor marker, decreased significantly on treatment from 564 to 29. This is on the lower part of the screen on the right side. You see the tumor, the shrinkage back in size. And she went on and had a liver surgery in August of 22. So less than a year from starting on her treatment. What was interesting at the time of surgery, when they tested on pathology, they found what's described as extensive necrosis. So really not any viable tumor cells within the specimen. And she's had no evidence of cancer since that time. She continues on surveillance with me, and I actually saw her earlier this week in clinic, and we're starting to move out the time interval between her scans. The hepatic artery infusion therapy has a very important role. It's important to highlight the safety information. We do, it is contraindicated in patients who have, limited liver function. So if you have high liver numbers or extensive disease outside the liver. And it's also important to talk about possible adverse events, but definitely is an important tool for patients in cholangiocarcinoma. And with that, we're going to move on.
Dr. Connell, sorry, can you go back to the slide where it shows the pump itself? I think it was missed. just so patients and...
Oh, yeah. Okay,
Yes.
sorry. Yeah. So this is the pump, just to describe it. A lot of people talk about it being like a hockey puck, which it is. So it's an FDA-approved device, and basically it's placed in the lower belly. Body heat powers delivery of the drug. And we'll probably get to this more in the question and answer section, looking at effects on daily life. But the therapy flows continuously as the patient goes about their daily life. You can see here a lot of examples of people being active with the pump. And the pump is refilled every 2 weeks while the patient is on active treatment. Sorry, I skipped that one. Okay.
Perfect. Thank you. Okay, so we will now be having our Q&A panel with our patients and Dr. Connell. For Amy and Rick, if either or both of you would like to answer this question, how did your doctor decide you were a candidate for HAI therapy?
Amy, you want me to go first? Whatever.
Sure, have at it.
So, welcome everybody. What had taken place, I was diagnosed with cholangiocarcinoma in February of 2015. At that point, I was given basically months, weeks to months to live. It was diagnosed very late. Went into full systemic chemotherapy. And then from there, that did not work. So from 2015 to early 2016, went through it. It helped me stay alive, but it wasn't getting me any further along. And then I was presented with the opportunity for HAI and the pump. And at Sloan Kettering, where Dr. Connell is where I went from the Chicago area and had the pump implanted in 2016, February 2016. And like her patient, I went for basically a year, and it did exactly what was prescribed, and that is to decrease the size of the tumor. And I was allowed to have it resected at Sloan Kettering in the next year in 2017. So it was what, as everybody has said, saved my life as a part of HAI. So, and I'm extremely excited to be involved with this and answer any questions going forward. Amy?
Yep. So similarly, I was diagnosed in around this time in 2021. So coming up on the 3rd year anniversary. GemCis was started, not resectable, having a large centrally located mass involving both the left and right lobes of the liver. There pretty much wouldn't have been a liver left if they had resected. The GemCis, this was before Durva was added, just before, wasn't successful. There was some progression. And at that point, I made a mistake. I wasn't going to an expert. And I fortunately live in New Jersey, so accessed MSK, an expert at MSK, who recommended the pump. And after reviewing my options, decided to go with the pump. I appeared to be a good candidate for it. No mets outside the liver, good liver functioning overall at that time. And, unfortunately, I'm not in the situation where I ever became a resection candidate, but it's definitely kept things under control. And I have no doubt it's not only bought me time, but really high quality time.
Great. Thank you, Rick and Amy. Dr. Connell, can you share a little bit more about who may be a candidate for the HAI therapy?
Yeah, so, this is always a question that comes up. And so, in general, for patients with cholangiocarcinoma, the absence of any disease outside the liver is one of the criteria that we have. Having said that, if somebody has, for example, some like regional lymph nodes, that wouldn't necessarily be a reason not to proceed with pump placement. Or, for example, if there's like a small lung nodule, that often comes up if it can be ablated, but really very limited or no extrahepatic disease, as we call it, or disease outside the liver. Good liver function, I mentioned earlier, because this drug is primarily processed by the liver. Also, it's an operation, right, to place the pump. So the patient has to be fit to undergo an operation. And I think one issue that's always important to raise that I always say to patients when they come to clinic is that the hepatic artery infusion therapy is not replacing standard chemotherapy or systemic chemotherapy. We still give it in conjunction with some systemic chemotherapy or modified, but it's modified. So it's sometimes patients come to see me and understandably they think that they will have this alone and it's a break from general chemotherapy. And I try to explain that I would still give some modified general body chemotherapy at the same time.
Perfect, thank you. And I know you said that there's no metastasis outside is one of those considerations. So is this only for patients with intrahepatic, or can patients with extrahepatic cholangiocarcinoma also qualify?
Yeah, so we don't have data for patients with extrahepatic cholangiocarcinoma. So the pump is only used in patients with intrahepatic cholangiocarcinoma.
Thank you. Rick and Amy, if you can share, what were some of your considerations when you decided whether or not to get the pump implanted? Amy,
Well,
I will.
no.
Go ahead, Rick.
No, that's fine. Amy, feel free. Go ahead.
Okay, so for me, I basically looked at I'm kind of a data-driven person myself, so I looked at the data on the hepatic artery infusion pump versus some radiation protocols versus FOLFOX or FOLFIRI, and it looked like the pump was a really good option in terms of the information that was out there on the stats. So that was a big driver for me. Also, I think that I was favorably impressed with the doctor I met with at MSK and with the surgeon at MSK, and felt that I would be in good hands, and that, the treatment, there would be options aside from that if things didn't go well. And so those were sort of the considerations that guided my decision to have it.
So for me, when I was initially diagnosed, the situation was I was, again, given a very short period of time to live. It was pretty significant. When I started the full systemic, I went along, and after 1 year of that, I was in Chicago at the time getting treatment, and they had said that it was not possible to resect the tumor. They could continue, but they were, again, get my affairs in order, as they would say. So I went through that 3 times to basically for the worst. But that was the thing that led me, and it so happened by somebody at the medical institution in Chicago that forwarded me on to Sloan Kettering, and that's where I met. And so my options is to move forward with this, or potentially I wouldn't live through much longer of the chemotherapy. And just to note, that my pump was inserted in 2016, the resection in 2017, and I go every 6 months now for scans and labs and things. And I am, once the tumor is resected, I know some people can, some people can't. I have been cancer-free. I was just I go to Duke University now, which is closer for that kind of thing. And everything is since the resection, and this is now going on, 9 years from it all starting. But that was the initiative, is the pump, and I'm a firm believer for people to consider it and think about it as a potential treatment option. It might not be, as Dr. Connell said, there's only certain types, certain people, certain things, but it's something, and I'm glad you're doing this to make people more aware of it as a treatment option. So.
Thank you. Dr. Connell, I think you mentioned good liver function. Can you explain what that is? Like, what do you consider good liver function?
Yeah, that's a good question. So, we look, I look when I see patients, I always get blood work done when I see the patient. And I think importantly, we're looking at, liver health overall. So there's certain features in patients that if we see any signs of what we call like portal hypertension, which is like a back pressure on the liver, or any issues with portal vein thrombosis or clotting in the portal vein, the concern is that we're not going to be able to safely and effectively deliver the dosing of the FUDR. In terms of the blood work numbers, what I found, because I do this in 2 cancer types, in colorectal cancer and in cholangiocarcinoma, there's no sort of upper limit of normal when we talk about the ALK phos, right? One of those liver enzymes, because actually what I find in my patients that I have with cholangiocarcinoma that I treat is actually, as you're responding to treatment, the numbers improve over time. But we have to make sure that the drug can safely be cleared by the liver. So it's really looking at the bilirubin. And sometimes there can be certain simple features such as being dehydrated, or there's some patients who have like Gilbert's, and you just check and see what the bilirubin is like. But it's really looking at the blood supply into the liver, the overall picture. Is there any concerns in terms of back pressure, or clotting or thrombosis, as well as looking at the blood work. There is no upper limit of normal in terms of an ALK phos, I would say. But a high bilirubin is something that we would need to investigate and see what's the cause of that, and whether it's reversible or not, prior to recommending a pump. Mm-hmm.
Great, thank you. Can you share, Dr. Connell, what can patients expect for the surgery to implant the pump?
Yeah, so in terms of the surgery, and Rick and Amy will describe this probably much better than me, but it's a relatively straightforward surgery, I would say. What's important to tell patients is that in patients who've not had a previous gallbladder removal, we generally will remove the gallbladder at the same time that the liver pump is placed. That's something sometimes in the medical oncology clinic I forget to say, and then the patient says it to me afterwards that the surgeon mentioned it. So if you still have a gallbladder, you will have a cholecystectomy at the same time as placing the liver pump. The operation itself, the pump is pretty superficial under the skin. Usually when it's done without an operation at the same time, patients can go home within a few days. We also now have newer techniques, which not all surgeons are doing, but like robotic and laparoscopic and different things like this. And then what I say to my patients, honestly, is that the adjustment period, I think at least, is the initial weeks at home, because the pump, you're adapting to having the pump there, and it can be a little bit swollen and puffy to begin with. A lot of people are side sleepers. They find that they're kind of finding a new sleep position. There can be some fluid overlying the pump that generally resorbs back over time. So it's that sort of adjustment period in the first few weeks after being discharged from the hospital. But the hospital stay itself is relatively short and straightforward. So hopefully Rick and Amy had a similar experience to what I'm saying, but that's what I generally tell people.
And I would,
Perfect.
I will go, just what was said is exactly right. I went from Chicago to New York, went through the pre-op and had the pump implanted. And if I believe correctly, I think it was 4 days later that I was able to fly back to Chicago, and recuperated for about 3 weeks or so, with this, just what Dr. Connell was saying, just for things to kind of heal. But at that point, and I know we'll probably get to it, at that point, I was able to begin, walking and doing things that I hadn't been really able to do just health-wise. But once the healing process kind of took place, it changed my whole life as it related. I still was going through chemotherapy to attack, my tumor, but it's what she said is my experience. So it was pretty straightforward. But Amy, you can expand and see what you say. It was, but just like Dr. Connell said, it was pretty much similar to that. So.
And my experience was also pretty similar to that. I was in the hospital 3 nights total. Weaned off IV pain meds pretty quickly. and really went home and never even took any narcotics orally at home, just managed it with over-the-counter stuff. In fact, I probably felt too well because I think I like being active, and walking is good. I may have overdone the walking. I was going out for 4 or 5 mile walks, probably within a week and a half, and ended up with a little post-op bleeding and back in the hospital. But that was only 2 days, resolved without transfusions, and then everything was fine. So it really was a pretty unremarkable recovery after the surgery itself.
Thank you. Dr. Connell, can you share how long chemo might be suspended prior to surgery?
Yeah. So in general, the recommendation is to hold chemotherapy anywhere between 3 to 4 weeks prior to surgery. The decision on exactly the time frame really depends on the individual patient and what's been happening with the blood counts on the chemotherapy that you've been on before having the surgery for the pump. So, for example, if somebody has needed a lot of white cell booster shots, Neulasta, different things, had issues with low blood counts, then the preference would be to go closer to 4 weeks. But we've definitely, advocated for putting a pump in, 3 weeks, even 2.5 weeks out in patients who have very good blood counts. Mm-hmm.
Great. And can you share how soon does the HAI therapy start following surgery?
Yeah, so the liver pump treatment starts at 2 weeks from surgery. Usually what I do in my patients is, because there's been a hold in some treatment before surgery, right before I start the liver pump treatment, I actually get a new scan, even though it's only a matter of weeks, but I really want to understand what, if anything, has happened in that time period that they've been off treatment. So a lot of my patients are traveling from out of state or from far upstate. So I'll generally get them a new scan the first day that they come into me for the liver pump treatment. And I do that at 2 weeks from surgery. And I tell them exactly what I see. Look, this looks the same as the pre-surgery, or there's a couple of millimeters growth. This is our new baseline. This is what we have. And then the systemic or the Metaport or general chemotherapy will start at 4 weeks from surgery.
Is systemic chemotherapy generally done at the same time as the HAI therapy, and how is that managed?
Yes. So for patients, you'll generally be coming in and out every 2 weeks. And as I said, we start the liver-directed treatment at 2 weeks, and then we defer and start the general chemotherapy at 4 weeks. After that, every 2 weeks when you're coming for treatment, you'll have the liver pump accessed, and you'll also have general chemotherapy. In terms of the liver pump, the drug is given once a month. And on the 2 weeks in between, you have a flush, which is generally just heparin and saline. Sometimes some steroid can be added in if the patient is having, some higher liver numbers on the treatment. But every 2 weeks, the liver pump is accessed. You do not get drug every time. It's every second time. And once you start the general chemotherapy at 4 weeks from surgery, it goes every 2 weeks, very similar to what the experience would be on chemotherapy on its own. The choice of the systemic or general chemotherapy is really dependent on what the patient has received previously, what the goals of treatment are, how they're feeling in general. Typically, I would say that patients, I quite often will see people who perhaps have had gemcitabine cisplatin, I think as Amy had in the beginning. So in those patients, I'll often either continue them on gemcitabine oxaliplatin or gemcitabine alone with the liver pump treatment. But there's several drugs that are safe to use, but it's an every 2 week regimen. And then I scan my patients every 2 months to get a sense of how the tumor is responding to the treatment.
Okay. Can you share how stringent the protocol for chemotherapy is? And then Rick and Amy, if you can share if you've ever had to stop chemo due to any of the changes within your own liver function tests.
Yeah, so I guess I'll start from the medic point of view. So in general, what I would say is that patients tell me that they feel better than they have on the chemotherapy that they had previously, because even though you're still getting general chemotherapy, the dosing is modified slightly when it's given with the liver pump. Um, so when patients come for treatment, and as I said, a lot of people for me come from out of state, they come in, they're feeling well, and I tell them in advance that there's going to be some day that you come to me and I'm either going to need to reduce the dose of the liver drug, or I'm going to have to hold the treatment completely. And that's very, very normal. That's to be expected. And it can be very disappointing, particularly when people are investing time and effort to come for treatment. But there is strict liver numbers that we follow, because there's a very small but real risk of causing damage to the bile ducts or causing biliary sclerosis. So it's very stringent. Usually what I've seen in patients is that typically happens after the second or third dose of the drug. And that's what I tell them, but not to be surprised if it even happens after the first dose of the drug. Also, patients nowadays are very informed, and all the information on what's out there. And with general chemotherapy, you would never reduce the chemotherapy down to like 25% of what you're giving, right? So again, I'm very honest with patients and I tell them, look, if I need to hold the drug, when I restart the drug, when the numbers are better, you're going to get 25% of the original dose. So for example, if a patient has 200 milligrams going of the liver drug, when I restart them, it'll be 50 milligrams. And that's something that we would never, ever do with Medipore chemotherapy. And I think what I found, at least in patients, is that honesty and just being direct and explaining that, then they understand that from the beginning, and that I'm going to explain, look, this is to protect the liver and we want to get a response but not cause damage. But just being very upfront from the beginning in that regard.
Thank you. Amy and Rick, can you share if you've ever had to stop, your chemotherapy regimen due to like liver function tests being abnormal or anything like that? And how did you kind of process that?
First, I did not. And what Dr. Connell, I went back and forth from Chicago to New York, and it was never stopped. I can't say for sure that it was ever, the dosage was ever adjusted. I don't recall that, but I never had any issues where it had to be stopped or I had to stay in New York, but I would go get the treatment, scans, lab work, discuss with my oncologist, and then basically head back home again. Nothing that I recall that even that the dosage was changed. Now that I could be wrong there because I don't remember that specifically, but it was never the point where, oh, by the way, we can't do anything. You either have to stay and go home and then come back. That was never the case. As I know that for a fact. It was whether the dosage was changed, modified. I can't recall that, but I felt fine through it all. I'm not gonna. It was such a difference from the full systemic. I mean, it was a life changer for me to be able to do that and know that it was working based on the scans and lab work. So just want to reiterate that. So Amy.
Thanks, Rick.
Yeah. I've had a bit of a more circuitous route, I guess. And I sort of think about the pump as kind of part of the toolkit that docs can access to kind of hit things as they come. I generally describe myself as being in the whack-a-mole group, meaning I'll have a period of stability and then something new will pop up and then a determination is made of the best way to attack it. So I'll try to do this in a very succinct way, but it's a little complex. So when I first had therapy through the pump, I think I had a total of 5 cycles along with the gem oxali, which I tolerated very well for the majority of it, felt fine, no real issues. Good response, my CA19-9 went from like 1500 to maybe 50. Things on the scans were showing a lot of necrosis, since the big mass I had was largely necrotic, it appeared. unfortunately, so I started in June of 2022. In October of 2022, there was a small area of spread near the confluence, even though the rest of the large mass appeared to be necrotic. So we decided at that point to go to ablative radiation therapy because there was a concern that the mass could just compress the bile ducts and that would be a problem. So the fact I think that I had ablative radiation therapy at that point, it makes the subsequent scenario a bit more complex, but that seemed to work really well. You know, that new area was necrotic then, but then I got another new little mass and we went back to the pump. And that time I got 4 rounds in with the pump with very good response. But then I developed high bilirubin and alk phos and had to basically go off of everything for 6 months. My sense is that wasn't from the pump, but it appears that I had a radiation recall reaction from the gemcitabine, and that the gemcitabine and the radiation kind of triggered a response that irritated my liver. So I had to basically stop all treatment for 6 months. And at the end of the 6 months, actually, I'm surprised it took 6 months. There was a little bit of progression, 1 new liver lesion, which really wasn't bad. Everything else was stable, and probable small mets to my lungs. So we went back to the pump, and this time I got the pump plus 5-FU because my doc does not want to go near gemcitabine again. So that I got, I think, 2 cycles of the therapy through the pump with that. And then my alk phos and Billy were trending up. I should say my oncologist is conservative, very interested in preserving liver functioning while keeping things stable. So we stopped after 2, but the new mass in my liver resolved. So just with the 2 and the 5-FU, that resolved. Things appear stable in my lungs. I'm still getting the 5-FU every 2 weeks, and the pump is there if there's something new in the liver, and we'll go back to it. So yeah, you know, there have been some, there was a 1 6-month period where I had to stop all treatment, but like, as I said, I think that was more because of a radiation recall reaction than because of damage to the pump from the pump chemo.
Thank you, Amy. That's helpful. And Rick, to give both perspectives that are a little bit different and unique, but still it kind of encompasses the spectrum. Dr. Connell, can you share how like the Y90 procedure might affect a patient's ability to receive HAI therapy?
Yeah, this is a very good question and one that comes up quite a lot. So the honest answer is, many years ago, Y90 prior to pump placement would really almost be a relative contraindication, I would say, to putting in the pump. My preference still would be to give liver-directed treatment prior to doing a Y90 procedure. And as Amy said it herself, I mean, it's an extra tool to add. And I find that in the patients that I see, with the liver pump, right, you're treating the disease that you see and also the little tumor seeds in the liver. So you're treating the entire liver. So you're treating the micrometastasis or the tumor environment. We can give very high doses, consistent doses of FUDR in. When a patient has had Y90 previously, in general, what I see is that I can't get as consistent or as dose intense levels of the liver drug into those patients. Having said that, now all of these techniques are getting much more selective. And so if somebody has a very selective Y90, and this is something that would be discussed at our tumor board, it's definitely not an exclusion criteria to getting the pump, but it has to be carefully looked at, and looking at the the blood supply into the liver, the area that was treated, to making that decision. But very often what I'll see if somebody comes to me for a second opinion is that they're most likely being offered a Y90 by their local treating center, and the decision is between going ahead with Y90 versus putting in the liver pump. And in those patients, my recommendation is to do pump first, because Y90 is available to do later on. So that would be the preference.
Okay, so that answers the question about whether Y90 could be done post the HAI pump, and it sounds like that is possible. Yes. Mm-hmm. And then in line with previous therapies, or patients who are on, have done first, second, third, fourth lines of therapies, is HAI pump something that they can also be a candidate for?
Yeah, so in general, what the most typical scenario I would say in patients with cholangiocarcinoma is that they present similar, to Amy and Rick, in that they've been on first line chemotherapy. Usually it's gemcitabine cisplatin. Nowadays, gemcitabine cisplatin with the durvalumab. And they maybe are seeing stability or some plateauing of the response, or potentially some slight progression in the liver. It's liver limited disease, and they're looking for a better option. We do also use the pump in patients who are not previously treated. But I can see a patient where you've potentially had 1, 2, 3 lines of chemotherapy, and as long as the same criteria apply, such as the good liver function we've mentioned, really liver dominant or liver limited disease, the liver pump can be used. What I would say in general is that any chemotherapy can change, the body's ability to take the drugs, and your liver texture and how you tolerate drugs. So again, what I found, at least in the patients that I treat, is that the earlier I've used a liver-directed treatment in terms of the HAI pump, the better the responses I've seen in patients, and the more consistent that I've been able to treat those patients with good effect.
Great, thank you. Amy and Rick, can you share what your experience with getting refills has been with the HAI pump?
Sure. As I've been getting refills now for 2 years, every 2 weeks, it's no big deal. It's really very easy. Now, I probably should say there probably is patient variability depending on the pump placement and how easy it is to access. I'm very, very fortunate. Mine really sticks out. Chemo nurses smile when I lift up my shirt and they see it. So the actual process of, draining it and then refilling it is honestly extremely easy. There's really no discomfort at all for me at all. And so I'm lucky. I'm a less than a 15-minute drive from one of MSK's satellite facilities, so it's not that big a deal. My understanding is if you're not getting treatment, for some folks, you can actually spread it out longer than 2 weeks, that there's something else I forget, is it glycol that you can fill it with that will buy you more than the every 2 weeks if you're not on active treatment. Because my liver is a little touchy, I've been getting dexamethasone through the pump every 2 weeks. So I do go every 2 weeks. And even when I'm not getting active chemo through it, I go every 2 weeks for the saline, hep, and dex. But it's really not a big deal. And, I get the 5FU while they're draining and doing that, the setup, and it's all pretty easy.
Thank you, Amy. Rick?
My situation, once I went through the tumor resection, I think I had a bit of chemo right after that for 1 session, maybe, or 2. And then from there, I've gone to what they call glycerol, which is to keep the pump maintenance or active. And I go every 8 weeks to have that done. And like Amy was saying, it's very straightforward. They basically take what glycerol is in there, that the pump will actually, under pressure, it will come out. They'll flush the pump, and then they'll put a new round of they call glycerol. I think that's what there might be another name for it. It'll go in, and then it'll keep the pump active, which I have still today. Should the need arise that I would have to go back for further treatment, the pump will remain active. You can't let it go dry, as they would say. So that's what I've had, and I've had that since early in 2017 after my resection to today. And I was just, again, at Duke, as a part of my procedure of scans and labs, they'll do that with my pump. So it happens every 2 months.
Thank you, Rick. Dr. Connell, can you share what patients need to keep in mind about when they can and can't, what they can't or cannot do while living with a pump?
Yeah, so this is always a very interesting question. I think Amy and Rick will be able to speak more to this, but there is, a lot of misconceptions and myths out there, I think, about what a patient can do. I think what I generally say to patients is that, in the beginning, you really have to be very, very mindful. In patients who are active, what I generally say to patients is to have like a binder, an abdominal binder, or some sort of compressive wear, that if they're doing more activity. You do have to be mindful of like weights that are being lifted in the beginning. The concern is that the pump is just under the skin, so it's on the surface of the abdominal wall, and also the connection to the catheter or the tubing to the liver. And in some patients, the liver, it doesn't happen in many patients, but the liver pump can flip in the belly wall. The honest answer is, over time, as with any surgery, some scar tissue will form, and therefore it's more stuck or fixed in position. So what I say to patients is there's more flexibility with what you're doing the further out you get from the surgery. But definitely being mindful in terms of weightlifting, activity. I allow my patients to run. Biking is a great activity for patients. I do, hot tubs, anything that heats it up, that is an issue, but you can swim. That's often a question that comes up. The issue with heat and hot tubs is that because, particularly when the liver drug is within the pump, it can speed up the rate of infusion into the liver. Scuba diving is a no. And then certain things like contact sports is just being mindful. But they're usually some of the questions that come up. I do let my patients ski. I tell them to have a binder on. I do let them hike. And as I said, it's just getting a sense of it over time. Unfortunately, what I'm seeing where I am is I'm seeing a lot of young people, right? And these are very, very important questions to them, because so much of your journey through your cancer care also has to do with your mental health. And for me to tell a patient that you can't go running or you can't go hiking because of this, that has huge implications. So I think be mindful, but definitely it does not stop you from being active. And perhaps Rick and Amy can speak more to that.
Yeah,
yes.
I will. Let me just
go ahead, Rick.
It's a good. Once I kind of got through everything with the recovery of the pump, I used to run. I don't run anymore. I do walk a lot. Maybe not as much as Amy, but I do walk. I stay away from saunas or steam baths and hot tubs just because my oncologist at Sloan said, don't do that. I mean, Dr. Connell's a little bit better. She's a little more lenient. The one I had, she just stay away from those kinds of things. Now, I will admit I play golf just about every day, good or bad. I do play golf, and I do wear a belt, a support belt, to just for that reason that she just said. Preventive, I've never had an issue. I've never felt anything once. Now, I know it's there. I mean, you'll always know it's there, but never had an issue. But I do precaution with a belt, a support belt, when I'm playing, and even when I go walking, I usually have it on. But no scuba diving, but I stay away from those high heat elements just because I don't want anything to affect it. But that's my plan today.
Amy, what about you?
Well, before I was diagnosed, I was extremely active. I was mountaineering, rock climbing, snowboarding. So the impact this would have on my physical activities was really important to me. And the good news is it's been relatively around the edges where I've had to cut back. I don't rock climb because you have to wear a harness, and wearing a harness it just really wouldn't work and not worth the risk of a fall and knocking it out of place. So I did give up rock climbing, and I actually gave up snowboarding, again, not because anyone said you absolutely have to, but to me, the risk of a fall and knocking it out of, I just didn't want to do something that would risk taking away this option that I have. I snowshoe instead. I do cross-country skiing instead. Since the pump has been put in, I've climbed Mount St. Helens. 3 weeks ago, I did an 18-mile hike in the Adirondacks. I just got back from Colorado, where I hiked 5 out of the 6 days. And the 6th day, I did a 23-mile bike ride. So it's really not, it's not had a significant impact on my level of activity, which I'm really thankful for. I still do, I've moderated the amount of weights I lift, but I still do weight training because you want to keep those bones in decent, keep osteoporosis at bay. So I still lift it at modest weights. So it's really not been a huge impact on what I can do.
Thank you, Amy. Dr. Connell, can you share a little bit about what side effects might be possible with the HI pump?
Yeah, so in general, what I say to patients is what I said early on, is that I find that the hardest part, I guess, is the kind of learning, the adaptation phase right after surgery. In general, patients describe feeling better than they have and better physical functioning than they have on traditional chemotherapy alone, because the dosing through the Metaport or systemically is lower. The main two things to watch out for, really, number one is risk of ulceration. So this was seen very early on in studies that were done with the pump. So in our patients, we'll have them on protonics or something to help with the lining of the gut, even if you're not having any issues in terms of reflux. If a patient of mine, is having issues with like acid reflux or sort of like, pain in the upper belly, I'll have a very low threshold to get an endoscopy and take a look and see if there's any inflammation there. So that would be one thing. But I think the main thing we watch for is looking at the liver toxicity. And I think, understandably, as a patient, you're concerned that, you're going to get jaundiced, that there's going to be a bilirubin rise. The honest answer is that in the vast majority of patients, we catch the problem before it's visible. So that's where the conversation around the blood work and adjusting the doses is very, very important. The key thing to watch out for, though, is if a patient does notice any signs of jaundice, yellowing of the skin, itching. Itching can often be like one of the first symptoms that a patient has, and having a very low threshold to check that out. I do things like we talked about the steroids in the pump. I put patients on Ursodiol or Actigol, which if you read the box, they say you get it for gallstones, but it helps kind of clear liver inflammation. Hydration can be very good. And also, if a patient of mine hasn't had like an MRI to look at the bile ducts in detail, I'll get an MR cholangiogram. What I would say is, in terms of side effects that patients have, if somebody develops itching, it can be it can really impact day to day, I would say. I'd have a very low threshold if someone starts describing that to me to really investigate and make sure that there's not any issues emerging. But in reality, the issue is picked up ahead. And I think, similar to what Amy described, I keep a lot of my patients on like the steroid, or I wean them slowly off the steroid fill before I transition over to glycerol, even if the patient is or is not on active treatment, to make sure that that we can safely transition over to glycerol. And usually I'll have my patients stay on the Ursodiol a little bit longer while I try to get the steroids out to do that. Mm-hmm.
Can you share how long active treatment lasts?
Yeah, so this is a very good question. So, we've heard from both Amy and Rick two different scenarios, I guess, and I think that just shows the spectrum. And the honest answer is, in general, what I've seen with patients, I would say in general, it takes close to a year for patients. And at that point, we tend to have a sense if the patient is going to get to a surgery or not. If you get to a surgery, then in general, if I've given a lot of chemotherapy beforehand, I don't necessarily give any more chemotherapy after surgery for cholangiocarcinoma. So the treatment finishes at the surgery date. The transitioning off the steroid hepsaline fill to the glycerol will depend on the liver enzymes. In another patient, if you've had a very, very good response, but maybe, and you've seen a lot of necrosis, but perhaps not to a point that we can offer surgery, then the honest answer is it depends on how the patient is tolerating treatment, what exactly I see. I am in general a physician who favors giving chemotherapy breaks if or when it's appropriate, because I think physically and mentally patients need that. So I've done a few different things in patients where perhaps I've given a break from the systemic chemotherapy and kept the liver drug on board for a little bit longer, or vice versa. I also do use techniques such as radiation, such as ablation in patients. And I think some of this also comes down to that first consult. If a patient is coming and looking for a liver pump, realistically, what do we expect the outcome to be, right? And listening to the patient and what the side effects have been on chemotherapy. But if you do not get to a surgery, then it's treating it like, I guess, a chronic disease where there's periods of time intensifying, de-intensifying treatment, taking a break and using something different.
Dr. Connell, how long does a pump stay in following HAI therapy?
Okay, so the minimum we say for somebody, if we can clear the liver of the cancer, is at least 2 years. Our preference is for patients to keep it in as long as possible, and Rick is a very good example of this. And really, with the glycerol fills every 8 weeks, every 2 months, it's really not so inconvenient to patients. And a lot of the time what we find is, and again, similar to what Rick has described, is it's worked for you before, and then to keep it there in reserve. But generally it's 2 years if we clear the disease as a minimum. And some patients honestly do say that as soon as I get the 2-year mark, I want the pump out. But I would say to them that my preference would be to keep it in for longer. In a patient like Amy, where I would do exactly as her oncologist has done, where there's periods of time that I may go back to the liver-directed treatment or not. And so therefore, in a patient like Amy, I definitely would be advocating for keeping the pump in. And if a patient is at a point that it's becoming more difficult, for example, to attend for fills, what you can do is actually just let the pump run dry, but the pump stays there. But that would be sort of the other end of the spectrum.
Mm-hmm. Okay. Dr. Connell, can you share about the availability of HAI across the country? I know that you're at MSK, but is this something that is available in different locations?
Yeah, so increasingly it is, and I think that this is becoming very, very important. And you can tell from my accent, I'm not from here, but I had heard about this for a very long time over in Europe before I came here. HAI therapy was associated with Memorial Sloan Kettering. I came here, and obviously this is what I've specialized in. But I think a huge part of the legacy of what's come from Memorial and my predecessors has been training people up, and that's beginning to percolate throughout the United States. So Rick has mentioned Duke. There's numerous other centers now. There's a huge drive to increasing access to HAI pumps and pump programs for patients. It's a treatment that requires a lot of communication between the medical oncologist and the surgeon. But we now have developed a consortium group, and there are multiple centers around the country that are placing pumps, are successfully treating patients with active therapy, as well as centers where perhaps they're not yet placing pumps, and they're not giving the FUD or the active drug, but they'll assist with pump flushes. So I can see some patients here that, for example, on active treatment will come to me once a month when they're due the drug, but then stay with their local doctor when they're due the flush. So we are trying to increase access, and there are more and more centers. And if anybody is in an area and you're unsure, definitely reach out to see, what's the closest center to you.
Perfect. Rick and Amy, for patients who are considering HAI therapy, what might they want? What would you want to tell them or suggest that they ask their oncologist?
Well, I'll take it, Amy, to start with, and you can.
Sure.
It's again, I knew nothing. I did not know anything about HAI when I first was diagnosed. And as Dr. Connell said, there are more and more institutions around that are moving in that direction. And I know that's taking place, but without it, I mean, it's a lifesaver in my mind, and what it did for me, and it drove me in the direction to pursue that, and I did, and it's something that I truly cherish, to having found out about it, and the people at Sloan Kettering, now the people at Duke, and just so everybody on here, I believe there are many other institutions that are coming on board or will be coming on board, but and I think I mentioned before, it's something that, how to best say this, it should be, if somebody's diagnosed and if they're in a location that might not have something like this, reach out, try to find out what you have, and understand that HAI is a potential treatment option. Might not be for everybody, but it is something that I feel strongly should be at least pursued and looked at if in fact you get cholangiocarcinoma, intrahepatic, I mean, that's the way that I would look at it. So that's my thought on it. Amy?
Yeah, not much to add. I think a lot of the questions I would ask a doctor during the consult are the questions that were raised here about, what makes you a candidate? What does the treatment look like? What are the limitations after you get it? I said, I always like looking at the stats, which I think when you look at the world of cholangiocarcinoma treatments, the stats for the pump are pretty good. And, I would add that, although my trajectory is different than Rick's, I really don't think I'd be here if not for the pump. I think that if I had gone to FOLFOX or FOLFIRI, I don't think I'd be here 3 years later still hiking and doing things. So even though I've not become, and I'm unlikely to become, a resection candidate or NED, I've had a lot of stability and I've lived a really high quality of life. So I would definitely encourage people to look into it.
I think just one more thing, if I might. When I was directed to Sloan Kettering and met with the oncologist and the surgeon at the time, the statement was made to me, I wish I knew about you before this. And that was back in 2016. And all I said back to her and to him was, I wish I knew about you back earlier on also. And it's just something, again, and I've talked to my regular medical doctor here, that if they see something, please, pursue it, potentially get additional things, lab work, whatever it might be, to help people know that they might in fact have this. Because as Amy said, and it's been told to me many times, that I would not be alive today if it were not for the pump. I was headed to die. So I don't mean to sound, but it's what it was the process that saved my life. So
thank you, Rick. Thank you,
Yep.
Amy. Thank you, Dr. Connell. I know that we are at the time, and I just know that there's a lot of questions that came in about very specifically like what may exclude them from being eligible to be a candidate for HAI. I want everyone to know you can visit the interaoncology.com website to get more information. That is the best place to go. and to ask your doctor about it. There's also a place on that website where it shows different locations where the HI therapy is available. So you can find a lot of information there. I want to thank you all for being here and for sharing your experiences and informing the community. We really appreciate it. Thank you. And thank you to everyone who attended.
Thank you.
Thank you very
Thank
much.
you.